You press the button on there. Just see this. Let's turn that on. You want to be sure that we see what I'm on about. There you go.
Right. Good afternoon, everybody. Welcome to this afternoon's board. Thank you very much for joining.
Just public.
Well, it's lovely to have you, and we're going to just, if you put yourself down there for the moment, we have some patients coming in, so we will be seating them at the end. Thank you very much. And we have apologies this afternoon from Tim Nolan, Non-Executive Director, and from A.D. Ray, Non-Executive Director. This is a meeting in public, rather than a public meeting, and the event is being live streamed. And for those who are tuned in virtually, the tech is set up so that you can observe. And to ensure that people at home can follow, we'll be asking all speakers to kindly raise their hand, briefly stating their name and role before every contribution. So thank you for being able to. I'm going to ask now for declarations of interest. The current register of interest is attached for information. Declarations made in advance of the meeting are already noted. Are there any interests to be declared for the agenda for us today? I can't see any hands, thank you. The nature of our board with partner members means that there are inherent interests because the organisations they lead or are part of, particularly items 7, 8 and 11, and the majority of reports in public for assurance and discussion. There are 2 papers for approval today, terms of reference for the South East ICB CEO Joint Committee and its Specialised Commissioning Subcommittee. And the level of conflict for this item has been managed with discussion between me and our Deputy Chair, and the perspective of members is important in participation in this discussion. I'll ask you now to look at our minutes of our meeting on the 11th of March for approval, please. Are there any comments or amendments? I will take those as approved. Thank you very much. And they continue to be presented in a streamlined format, capturing all the key information, and our meetings are recorded and uploaded. We turn then to our action log. And there are a number of items on the log that are for closure. If I ask first for the item number 1, is there an update on that item? Thank you, Hannah.
Yeah, so this, I'm Hannah Iqbal, Chief Strategy Digital Transformation Officer with Executive Responsibility for Governance. So this action relates to a governance review we undertook and have reported to previous board meetings. Given that the papers today set out yet more change for the ICB landscape and our governance, I propose that we close this action but keep a watching brief at later board meetings in terms of the emerging system landscape and any implications for our government.
Thank you very much. There are a number of items there marked closure. Do I have any comments or questions in relation to those? Thank you very much. I'm taking this questions from the public. There are, where possible, where items being covered in the agenda, presenters will answer questions during the relevant agenda item. We've received 3 questions relating to item 7, our CEO's report, item 10, South East Region terms of reference, and item 11, neighbourhoods. And we've also received one question which is not on the agenda for today, and therefore will be addressed after the meeting and published within 20 working days of the board. And that question is in relation to recent research by the Centre for Health and the Public Interest, CHPI, into the use of the private sector to deliver NHS public health. I'm going to move us then next to, we will have our resident story in due course when our guests arrive. So in advance of that, could I ask, please? Oh, I have no right. Guys, imagine best timing. Do please come in. No, we should. Oh, we'll need one more actually. I'll pop you over here. Wonderful. Well, thank you very much. So many people. Little people too. Thank you very much. Hello. It is wonderful to see you all here today. Thank you very much. And we are delighted that you would come and join us. We are being live streamed, as you will know. So this is being recorded so that people join us remotely. And we have one member of the public with us as well. And we're so pleased to see you today. And Rachel, I'm going to hand over to you to introduce our colleagues, to introduce us.
So good afternoon. For those on screen, my name is Rachel Corser. I'm the Chief Nursing Officer here at the ICB, and it's a huge pleasure to introduce our resident story for this afternoon. And just to remind board, at the last board we had the chair of the Health Innovation Network for Thames Valley come and talk to us about the work that they can do with us on helping to improve and transform some of the care we provide. And it was important that we perhaps brought that to life a little bit. And it's a huge pleasure that we've got Rebecca and Alan in the room with us today, and no longer baby Luna, but we're very toddling Luna with us to share the work that that they can describe the impact and the benefit of the work that we've done as a collaboration with the Health Innovation Network. And with that in mind, I will hand over to Eileen, who works at the Innovation Network, to talk to us a little bit more before we play the video.
Perfect. Thank you very much. So my name is Eileen Lovely. I lead the maternity and neonatal safety improvement programme for the Health Innovation and Thames Valley Network. And one of our significant programmes is improving outcomes for babies that are born too soon. And that work requires significant collaboration, system-wide working, and multi-professional working, which is really important. We have worked successfully across our network to educate and train our workforce to help them implement a particular set of interventions. There are 9 interventions, evidence-based, that have been published by the British Association of Perinatal Medicine, so BACM, and working collectively and system-wide, we've been able to implement those interventions. The most important of which is to make sure that babies who are born too soon are born in the right place, and so they get the right care at the right time. And I'd like to introduce Rebecca, Alan, and Luna. And do you want to go straight to the to the film? And the film is a 10-minute edit of a much longer filming session. We'll give you the story, and I'm happy to take questions. Thank you.
Sorry, everybody. Here we go. Right, got it.
Every day in the NHS, the first.
Yeah, telephone docs. No, we'll be there in a second. I'm sorry. That sharing?
Really hard, bringing those wide-ranging skills to the patient.
It means Travis. Yeah, so laptop. Go down. And then top, you need to turn it on. Yeah. Top. Yeah. Full screen it. And play. Got it. Sorry, everybody. There we go. Right, ready.
One couple's experience, and we're also going to meet some of the healthcare professionals who've worked together to make sure that they and their tiny baby got the right care in the right place at the right time. I felt some pains. It's about 1 o'clock in the morning on a Wednesday, and I thought it's probably nothing, just a little bit of pain. At that point, I was 23 weeks pregnant. 20 and yeah, they sort of like progressively were getting worse, but again, didn't really think too much. For context in terms of pain, I'd had a herniated disc in my first trimester, so that pain was off the scale, whereas this was sort of more like a niggle. But as it kept coming, the pain became a bit more frequent. I thought we should probably either call an ambulance or head to hospital. So we called ahead to our local hospital, and they said, just come in. What we didn't do was pack a bag, because we thought we'd just be in and out. So let's pack a bag. And yeah, we sort of turned up. I was examined, and they were like, oh, you're actually 6 centimetres dilated. You're in labour.
Just coming.
It's difficult to deliver that information in a way that anyone can process it, because you're going to a situation that's completely unexpected. Whereas if your term and you're in labour, you can probably deal with information a little bit better because you're prepared for that. It was just a Wednesday night.
Yeah, we have 4 months left, so we weren't planning to even head out that way.
These are a very, very high risk group of babies. And for this particular group of babies, there are small marginal gains, multiple small interventions make a huge difference to their outcomes. And so that's why we have centralised the intensive care, and we know that that has improved outcomes, and that's been proven both in this country but also in countries around the world, that if you centralise, you will get better outcomes.
We're given a lot of information about her chance of survival, any complications if she did survive, including disability later down the line. At that point, I was given that information. I also received my first steroid injection to help her lungs, and then my first magnesium sulfate injection to protect her brain.
We know that if we give mothers a large dose of steroids in 7 days before the baby's born, that improves the outlook for the baby. But beyond 7 days, it doesn't seem to make very much difference. And repeating that dose of steroids is not helpful. So you've got to time and estimate when a baby's going to be born very preterm can be very difficult. So timing those steroids is very tricky. Magnesium is a drug that, if given shortly before a very preterm birth, will also have very significant beneficial effects for a baby. Again, you've got to time that right. And there's been a very effective national programme improving the rate of magnesium administration before a preterm baby.
It's one thing to be in labour, to then have to deal with
thinking about what medical care your unborn baby needs if they even survive is incredibly intense. Do we stay here? Do we not stay here? Because we knew we'd have to eventually go to a level 3, but we didn't know when. And then the question was, well, what's the difference between those hospital facilities? Do you have, what specialisms do you have?
We're really lucky in that we have a really robust intra-uterine transfer guideline that we share collectively across our region. So it means that really robust conversations happen between both of those units. It means that the optimisation of that baby starts from the very moment the woman arrives in the level 2 unit. So for Rebecca's case, for example, she already had her first dose of steroids, magnesium sulfate. She was started on antibiotics even prior to that transfer happening. So we really was a seamless process for her.
Ambulance is here. Do you want to go? We have a team ready to go with you. If you deliver in the ambulance, you have a specialist with you, so that's covered. And we'll blue light you the whole way. I think we just said, yeah, let's go. Like
It was just
good to
made
go.
very
Let's go.
clear that it was the best place for us to be for the delivery, and that little one at certain gestation don't travel too well in ambulance, so she really needed to come in the right place.
Clinicians need to be brave and parents need to be brave about trying to transfer these babies. Now, the course of preterm birth is very, very unpredictable, so it's quite unlike term birth. Actually giving birth in the ambulance is really, really rare. And the overall net benefit is that you get very much better outcomes, even if you transfer people in late labour.
And the transfer was completely seamless. I was in the ambulance with a midwife and a specialist, a neonatal specialist.
We didn't blue light her there just because of the risk of that she might deliver in the ambulance, and we had all of the equipment ready if that was to happen. So if she was to deliver, we had equipment there to be able to keep Luna warm. We had equipment to be able to stabilise her, to be able to maintain her airway, maintain her breathing, and we made sure that that transfer was as safe as it can be.
At the time of birth, there are also further interventions that can be done. For example, optimising when you clamp the cord and delaying that until the baby's starting to take rest and establish breathing is really the best way to do that.
I actually asked a question about delayed cord clamping because that's what I wanted to do, even if she had arrived on time. And I think she had them for an amount of time before they needed to then give her support with her breathing.
We need to control the temperature of the baby. And whilst that might seem a very easy thing to do, these babies are very small, very thin and very wet. And it can be very, very difficult to hold the temperature at the right level. So we put them in plastic bags, we have them under heaters and warmers, and we tend to try and make sure that we maintain their temperature very, very accurately to stop them becoming cold, because again, we know that increases their likelihood of not surviving.
Well, one thing that couldn't happen, which I think probably happened with most births after a certain point, is I couldn't pick her up and hold her right where it was solid. I just had to leave her cage. Quite difficult. But I saw how small she was and I completely understood the situation. So once she arrived,
Kicking and screaming.
she was kicking and
She
screaming.
wasn't unresponsive.
No, she was very angry, actually, when she arrived. Alan got to cut the cord as well, which was, we didn't think we would be able to have that opportunity, so that was really lovely. And then she was whisked away, and we were told that, well, they explained the plastic bag to keep her warm. I'm not sure a better way that they could tell you, but yeah, so she was put in the warm bag, and then she was wrapped in some ball and bubble wrap and all that kind of stuff, so that we could actually have a cuddle, which we weren't expecting. So we do have a picture of us holding her as a tiny baby. So that was something, again, we didn't expect, but it got to happen. I mean, I couldn't have asked for anything better given the situation. I was expecting worst case scenario would be that she's just taken immediately and gone up to NICU, but actually we got to have the delay cord clamping. Alan got to cut the cord, we got to have a cuddle, and that was really lovely.
Luna being born at 24 weeks is very much at the limits of prematurity that we're able to support. And, every little thing that you can do to survive mounts up to help them with that. And sadly, it's not always possible, but I think in Luna's case, everything went very well and she came through our neonatal unit with very few complications, which was really important.
Thank you very much. I'm not sure she quite accepted that. So what's that you want it? Oh, it's wonderful. May I open it up now to colleagues, please, with any questions or comments? Amina as well. Yes, please.
Gosh, you cry there. I had twins and they were 35 and we thought they were small. So actually seeing me was quite. And I really reflected on you seem very calm and how were we able to help, and all the people that you sort of talked to or you were in contact with, how did they help contribute to the way that you were? Because I'm sure that had a bearing on Luna and the way you and your husband were really brought the best out of the situation. And I wonder how the team helped you with that.
I mean, there's so many. It is a difficult one. When we got to JR, Andy, our registrar, was great in giving us a lot of information and really he gave it so. Yeah, and it wasn't all scare statistics, which we had sort of previously, and then he sort of he was kind of reassuring with the way he delivered it. And then said, and bear in mind, a lot of these statistics are sort of 10 to 15 years old, so a lot's changed even since then. And then was it all Andy who explained what the magnesium sulfate does, what the steroids do?
I think
it's a bit of
I think it's just the manner in which the information is delivered. So when I was in labour, we actually received the same information as we did in John Radcliffe, but obviously in labour it's an emergency situation, but it was sort of just like said, so it's kind of done, if that makes sense. It was just because it had to be said. So that didn't feel particularly, oh, thank you. Yeah. So that didn't feel great given the situation. But I think it's down to, I think there's a lot of healthcare professionals, that are made for the job. So the manner in which they deliver that information is very much part of who they are. So it's calm and it's concise. I think one thing that was definitely important for me is I always have a lot of questions. And I was never made to feel that I was taking too much time. And I think that was also very important given the situation. That's probably there was never a point where anyone was like, oh, I don't have time for this, or can you ask me later? It was like, no, let's sit down and talk about it. We got a lot of diagrams as well, for parts of the journey. So, yeah, I think that answers the question.
And I'd just like to pick up on that. So specifically, the subject of counselling and antenatal counselling, and giving information in a way that's helpful and because it's difficult to process things. So on the back of Rebecca experience, we have just started actually to run a series of webinars which are nationwide, which I'm interested in. And they're delivered by somebody consulting the neonatologist in Oxford. So Professor Dominic Woods and Catherine and one of the advanced enabling nurse practitioners to help throughout the country have tools and structure so that they can get this complex information in a way that's helpful. So it's been really valuable feedback from this one.
Yeah, I mean, we're the kind of parents who wanted all the info, wanted all the numbers. There are others who didn't like getting spoke to, they didn't necessarily want to know all that, and maybe it's determining kind of, I guess they have to be given the information, but it's always going to be different depending on who's receiving it.
Thanks very much. I'm Ben Riley, I'm the Chief Medical Officer at the ICB. So I thought the video and what you've said describes a brilliant balance between an evidence-based approach and the best practice and the person-centered care that you need to use. That's the sort of goal really, to combine those two in a better way. But let's get a bit about what happened when you went home. How was the sort of care transitioning back to sort of normal life with a new baby? Not only was you the earlier delivery, but I guess you probably weren't ready at home, you know, in the same way that you might have been 4 months later.
No, we went. I mean, we also went living where we were supposed to be living. Tiny little flat, and then we had to have oxygen and tanks all over the place. It was just trailing a lot of cables.
Services, were services helpful with that sort of training?
But yes, yeah. I mean, it is a good question. I mean, from my perspective, we were kind of. It's like we were in training for those first 4 months for when she got home. So by the time it came around, we were already changing our prongs and putting NG tubes in and like doing all that stuff, which is valuable for us to have learned. And she was on oxygen at home for 5 months or so. Yeah. So and the feeding tube, which she eventually just had enough with it. And it was never going back in, but luckily he started feeding. But the teams, can you remember?
Yeah, so we had, when we left Stoke, we had, I think, 2 meetings, basically explaining what the going home process is, what we need to do, what equipment we'll need, because some babies obviously go home with, they just go home like an average baby. But with Luna, we were feeding her via a pump because she had a milk allergy, which is difficult to pick up in that environment with her so young, given the symptoms. But yeah, so we had a feeding pump and the oxygen. We were put in contact with the different companies that support that. We also then had equipment set up for physically, speech and language. Our community nurse, who we saw, I think, pretty much every week until her oxygen started to go down. So we knew we always had that support there. And what else happened? It was basically everything was covered. I think the important thing when we left was also that we were given access, like emergency access, if we need to, which we did actually need the day we got home. We ended up back in A&E.
Yeah,
because she stopped breathing, so that was a good return home. So yeah, so we were prepared with that. And as Alan said, I think because you're in hospital for that period of time, you are being shown how to do things. I don't think all parents, in our experience, actually, not all parents want to know how to pull an aspirate, how to change prongs. They don't want to know that, and that's just individual. But if you're going home with that equipment, you do need to know how to use it. But they were always very supportive, which is helpful.
They were pretty on. You should learn how to do this.
Yeah. And we were already from Dramatic. We were already doing it from there anyway. But yeah, I feel like we were well equipped with what we needed. I think normally when you go home, you have like your not your community midwife, but someone comes to see you. I can't remember what they're called. Every couple of weeks or whatever. And we did have that, and then because we were in hospital so often, we didn't get the community help. We haven't actually picked up either again actually. Yeah, because she's good. Yeah, I think it. And there's always someone you can ask. I don't know if you leave without having the extra things to go home and there is still that level of support because it's quite a big transition leaving hospital. I mean, that's when we ended up back in A&E. That was a shock because we were used to 4 months being able to just got to the building, get something to eat because there's always a nurse around with a baby. In A&E, it's not that. It's just you. It's straight to pediatrics. And that was a bit of a shock given the sort of experience that I had. And it'd only been the same day that we left.
Yeah,
So that was quite tough. Yeah, it was the evening. I got home at lunchtime and then back in. So, yeah.
A couple more questions. If that's all right.
Absolutely. Yeah. Please, Stephen.
Hi, I'm Steve Manas. I'm the Chief Executive of Royal Berks Foundation Trust, and I'm a partner member here on the ICB board. So lovely to meet you. And lovely to meet you. Thank you for coming. Just really interested. It's a build on Ben's question about actually signposting into or any wraparound kind of support from, say, the voluntary sector or kind of a support environment beyond the sort of medical type of support that clearly you had to focus on. So were you able to access anything like that from the voluntary sector or any other kind of wraparound support groups that you channel towards to support you both?
Do you have examples of what that looks like?
So I know kind of in the Berkshire setup where there is kind of again voluntary support groups around our neonatal kind of intensive care unit, and so again for families who have been through that kind of experience. So it was just interested in how that plays in as well.
Yeah, I don't think he did. I mean, obviously, sorry, but with the different hospitals, they have different charities. So Oxford is SNAP and Stoke is Burps, and there's always opportunity to be involved in some of the activities that they do. But that's very much if you see a post from the wall, take a picture, contact them rather than actively reaching out. So it's a little bit different. Outside of that, no, I think
we weren't contacted or anything.
No.
Right? I mean, we had the therapists that would speak to us in the hospital. But they're very different when they're between hospitals.
Yeah.
Very different. But
Would you have felt able to respond or want to respond?
thing is, it's like I can't 100% say that we weren't contacted because I think we were kind of like we were okay. Like
I think you're given
we're
the
getting
option.
to the,
Yeah.
I think it was we would have been given. I'm sorry, I can't remember. Some contact details should we need to speak to someone. But for us, once we were home, we were home finally, so it's like let's us do this, and we just went to the appointments that we had to go to.
I think maybe for other people, thinking more generally, it might be more beneficial to have a situation where people do actively reach out, because when you're getting ready to go home, all you're focused on is going home. You're not really thinking about a couple of weeks down the line or a couple of months down the line, how am I going to feel? Will I need extra support? Sort of play groups with other NICU babies. That's not really on your plate at that time. That's not really on your plate at that time. So maybe it's something that conveys an active sort of support network that reaches out when you aren't thinking about it, when you probably might need it at that point. And also leaving NICU, depending on your experience, every experience is different and every experience will be difficult. But I think you might not necessarily process it at the time and you process it later. So I'm pregnant now, and coming up to my pregnancy, like where I am, 2 weeks now, coming very close to where Luna was born, previously, before I came to terms with it, I was actually thinking about a bit of the, dare I say, trauma of what we went through before. So you might not, as I say, you might not deal with it at the time, but you might need that support a different part of the journey.
I think, Steve, just to pick up on that, in terms of the work that Ben does, we have a really well-established connection with the maternity and neonatal partnerships. So, and those are the experience of represented that help us to the problem is co-decided and try to learn these experiences and use that to drive change. Thank you.
Yeah, hi, I'm Nick Paul, Chief Executive. Thank you both so much for your story, amazing. Just building on what you said, Is there one thing that could have been done better when you look back at the whole experience? If there's one thing that could have changed?
In general.
In general, yeah.
One. I mean, really, we've done a lot of just singing the praises of the NHS and the care we've had, because she wouldn't be here without it. I'm sure there are things at times we maybe have things to say, but mostly just to each other. But there were no big.
We couldn't get straight back into making that seems a bit.
Yeah, that was that. I think they. What did they say? Did they call the babies? They have a phrase they call the babies of that NICU. They call them like dirty babies or something. So they can't.
Yes.
It's an internal thing.
Oh, is it?
Yeah, so they can't come to the I think. Sorry, I just need to keep it going.
Sorry, it's
Sorry.
traveling.
One thing. That's just a really difficult question. I think because when you're in it, there's so much information received. We still have a packet of documents that we never looked through when we arrived, because at John Radcliffe, because of her gestation, we were basically enrolled into loads of stuff. Don't know what they are, haven't read them, but we just said go for it. There are things that probably could change. I think one thing I don't think you're fully prepared for is the transition between the hospitals, like the different levels. So as an example, level 3 John Radcliffe is super on it with like disinfecting their hands and the level of hygiene, but because obviously the babies are very potentially unwell, or whatever you want to call it, there is a level in which they work to. When we went to Stoke, we were expecting the same, but it's not really NICU now, it's now more ICB. So we weren't really that well informed of the differences or what to expect. So again, like in John Radcliffe, you have a whole room where you can sterilise your breast pump equipment, but at Stoke it's like, I'll just use the sink in the kitchen. So it's like trying to adjust to what you've been used to. I think even if you went the other way around, if you went from a level 2 to level 3, that would be quite difficult to manage as well. It's just, I say that, I don't know how you would approach it, because again, when you're there, you're given so many leaflets about different things and so much information. It's so difficult to ask someone to walk you through. You sort of just go with it. So yeah, I don't know. That's a really hard question.
Yeah, it's tough. It's more to us. It was more the differences between the two places, 2 months basically, rather than one thing we would change.
But in her care, there wouldn't say there was anything.
Right.
There was one incident, but yeah, I don't. So I'm just thinking like.
Yeah.
Yeah.
She was really hard to cannulate.
We learned from it.
Yeah.
Being able to.
Yeah. So Luna needed a blood transfusion, quite badly. She needed it like sort of soon, and she had very tiny veins.
Sure.
And obviously, John Radcliffe is a teaching hospital, so they were trying for an hour and a half. And by the time I got there, I just said this needs to stop, because also when you're focused on the task, 3 different people focusing on task, Luna's covered under a sheet. So I think when you're trying to do it, you're just looking at this piece of skin, little wrist, whatever. You're not actually looking at the whole baby or considering that you're actually trying to do a procedure on a baby that can't cry, or so because she's intubated. So I think it's difficult. So that was really difficult. That was really hard, because it shouldn't have gone on that long. And obviously, people need to learn, but I think just that needs to be probably tightened up a little bit. An hour and a half on a baby that can't tell you it's in pain, it's quite difficult. And when I did bring it up a few times, like, this needs to stop, we were told that the blood will expire. So, and I said, well, that's not really my problem. If you can't do what you need to do, like, can we just stop, because that's our child that is struggling, and there's always more blood. I know that's probably not the best way to think about it, but
I think if someone was trying to sort out a cannula to give you a blood transfusion over an hour and a half, you would have stopped that within 10 minutes. So I think that was probably the only negative thing. We did have a situation where someone had mixed up the tubes for her. Was it the
Incubator, they got the heart.
When they put the tubes all the way around. The incubator, yeah, she did get cooked one time. Which was
About when they had the air,
the wrong way around.
no, cold air going into the lungs for 12 hours.
Yeah, so, but we had an apology for that. But yeah, the incubator's a new
That's-
nurse who just turned up the incubator and she then got cooked a little bit.
Yeah, we do need money. We go for a walk. Just to pick up, I think, on a couple of those things, Rebecca, as well. I mean, it is very complex system and it requires such an incredible amount of teams working, in harmony together. With the repatriation, we've learned a lot from you and listening to you and Alan about this, and so the adjustment from a level 3 neonatal intensive care unit to level 2 is considerable. And there is a different level of expertise within the staff, and parents have been used to one thing and now they're expected to be. And so there is a lot of work going on with the family integrated care teams around parents and caregivers, and looking at some competency documents almost so that you have to come from that level 3 tertiary centre and then have to really, show evidence that they know how to change the nappy. These guys knew how to manage the lines, they knew about data, but it's tricky and it's something that we're working on. And then in terms of the cannula, I would take that back actually, because Dr. Larry Adams has a particular interest in pain management of needs. So I would be very keen to talk to that.
Just on that, in the competency, that's a really good point. So we had a few times when we got to Stoke, that we would be going to pull an aspirate, so actually needs to be fed, let's sort this out, take a look, whatever. And thank you. And they were like, oh, you can't do that. What do you mean? We've been doing it for months. Oh no, you can't do, you need to do the competency. It's like we've been doing it. We haven't just arrived, we've been doing this for a couple of months. So you almost got into a bit of a, not a disagreement, but it's just quite irritating and stressful. You're like, well, we know what we need to do, but I think part of the problem was, so in John Radcliffe, yes, the handover. So in John Radcliffe, they have these huge board sheets that have everything on it. So the position within, the feeding times, aspirates, all that kind of stuff. And when there's a handover, it doesn't matter who it is, the handover is always the same. So this is this baby born at this gestation, and they just go through basically like a short history of the baby and then what's happening on that day.
Even if it was a nurse who had those 3-4 times before.
Yeah, it's the same. It doesn't matter.
History.
Same thing repeated every time. So they know it doesn't matter. It's just still repeated. At Stoke, it wasn't like that. It was more. So I would get in the morning, but like, can I see the chart? Because I'm used to reading it at dramatic. Can I see the chart since it's been going on? And it would be, oh, well, yeah, it's here somewhere. So, okay, but I have used like what's in the handover, what happened last night, I'm not sure. And there would be that sort of not the same level of detail in the handover. And I know they're looking after more babies as well, so it's a little bit more intense. But for coming in when Luna used to have a lot of DSATs and Braddies, mostly I think to do around feeding because of her allergy. I'd want to know how many she had in the night, how severe were they, like what do I need to know? And that information wasn't always readily available where it had to be found, or sometimes it wasn't noted correctly in the chart, and that also was quite tricky. I think again, some parents probably don't care that much, but we want to know like what's been going on. We want the detail. So I think it's different between people, but there definitely is a difference.
Yeah, we had a lot of measures in place at Stoke because of her feeding issues, and a lot of the time they weren't being followed because they just hadn't read what we'd written down for them to all.
Yeah,
that was frustrating.
Yeah, because we were trying to get her off the feeding tube onto the bottle. So a couple of the nurses there had spent a few shifts working out what the best temperature for the milk, best feeding position, what to do with her after, all that kind of stuff. And then you might come in the next day and she'll be just sat in a chair being fed by the pump, and it's like that's not part of the plan. So there were just a couple of discrepancies. Again, looking after multiple babies, so I know it's difficult, but that was when it's your own child, it's quite difficult to comprehend when you know there's a plan. So yeah.
Yeah, and I think that was the value. I'm so grateful to Rebecca and for talking to us and putting us into the film, because it gives us the parent evidence that we can work on repatriation issues and we can address. And you listen, actively listen, stuff.
It's so helpful for us because you've experienced the very cutting edge of what's possible. And so how you support patients through that, because everybody's learning with you. You're as expert as people who'll be looking after them, because we're all working together, and it is so helpful to have this feedback and visibility, and for you to have recorded it as well. It really helps us all to learn. We are sorry that we're going to lose you. Might leave us Luna, she's there. 5, 4. Oh, yes.
The only person ever to attend our board.
Will be 2 in
September.
But corrected in
January 19th.
But just to say, it's been amazing. I know there's a couple of the issues that are there, but overall, I mean, just stunning, to be honest. Like overall, an incredible experience, despite it being difficult.
Yeah, I mean, we mostly look back with joyful memories of it. Because that's what we're like.
Yeah.
To grab the happy products. Didn't we?
And yeah, we're going to John Radcliffe quite regularly, so we go back and it's like, it's not like, oh god, it was terrible. There's still a very positive feeling about that experience.
Yeah, I mean, the consultants were so important too. Like, we were there around every morning, weren't we? So we were just those parents who wanted to be there to get all the information. Like I say, some wouldn't do that or wouldn't be interested so much, and I guess that's different.
Yes, catering for people.
I'd be watching the brain scans and be like, what was that white? Is it white good or was black good? Like, trying to understand the parts.
And I think it's really important to note high risk pathway now. So our experience that we're doing a piece of work on a network of trusts to try to upskill our doctors and preterm birth medics on cervical then scan training, so that people like Rebecca and Alan reach out at 2 o'clock in the morning.
Yes,
there will be somebody on duty who will be able to do cervical net. It will be additional information to help the team in collaboration with parents decide whether a transfer to a level 3 is appropriate or not. So we've learned so much. It's informed so much of the work that we're planning to do.
I think it illustrates the kind of benefit of system work in integration with the innovation network. That's this is a really big example of it, and it is thank you.
Thanks for having us.
Thank you.
I think we've got to give Luna.
Yeah. Thank you very much.
Thank you very much.
Thank you so much.
Thank you. Thank you.
Thank you. Thanks very much.
Bye.
Just thank you, everybody. I think that was a very, very helpful way for us to ground and start our board meeting, and particularly that point Rachel raised of why does research and innovation matter so much? Look at what it needs to. Never let it be lost in our presentation. I'm going to move us now to our Chief Executive and Directors report.
and hand over to our CEO.
Very thank you, and Chief Executive, and I'm not quite sure how I'm going to follow that rest of the story, but I will endeavour to do so. If I can just begin with a question from the public in relation to my report, and the question is from Mike Edkind, and he says that given us in just 3 pages, the new table of model ICB core functions and activities references people and communities on 6 separate occasions: collection, convening, input, testing, co-producing, evaluation, co-design, deliberative dialogue, and fulfilling statutory duties. Will future Chief Executive and Directors' reports A, either be written in a way understandable by the generality of residents, or at a minimum have a plain language summary, and B, include a paragraph describing public community engagement activities undertaken in the previous 2 years. C, be published on the Bob ICB website as news item not tucked away under all papers. So, Mr. Edkind, thank you much for the suggestion. We do always strive to use plain language in our communications and recognise the importance of having all papers that are accessible to all our residents. And as part of our statutory responsibilities, board papers are filed in one accessible location on our website, clearly marked and not under the news section. But we are very grateful for Mr. Edkind's input and will incorporate more public involvement activities into Chief Executive Director's reports moving forward. So thank you. In my report, I reference planning. We're going to touch on that later in the agenda, so I'm not going to say anything now. I also reference the changing system landscape, and in particular changes for ICBs. And again, we have a separate agenda item covering that. Just want to highlight to colleagues, it's not actually in my report, but on 7th of May, we had our annual oversight assessment meeting with the regional team of NHS England. That's the annual meeting when we look back on the previous financial year and performance of the ICB, both in terms of financial management, operational delivery, and quality of services in our system. We've yet to receive the written feedback in relation to the assessment meeting. Overall, the verbal feedback was positive, and the regional director noted significant improvements in the ICB during the course of the last financial year. The resident story we just heard highlighted the importance of research and innovation, and with that in mind, I was very pleased that I was able, in the company of Hannah, our Director of Strategy, Transformation and Digital, to attend a presentation organised by the Oxford Joint Research Office regarding the role of the ICB and how the ICB work more effectively with system partners to align research and innovation in our system to some of the operational challenges we're facing as a system. The Oxford Joint Research Office is a partnership between Oxford's 2 universities and the 2 trusts, Oxford Health and Oxford University Hospitals. And it was great that everything was well attended, included by many of our academic partners and also by the Deputy Director of Research at NHS England. I'm now going to hand over to my executive colleagues, who are just going to comment on the sections in the report, starting with Matthew, our Chief Executive Officer.
I was just going to take any questions from the report as the present report activity. That's all working around ADHD.
Thank you, Matthew. Ben, Chief Medical.
So in my summarise what I've been doing the first 2 months in the role. That's involved a lot of internal meetings, getting to know everybody and their roles and how the teams work, and also external meetings with partners. That's including some of the academic partners and also local authority partners. There's exec sponsor for partners request as well, so sort of summarising those there. So as a director of the team, looking at how we sort of prioritise our work in the current situation that we find ourselves, both with the model ICB announcements and changes to NHS England, but also with the wider system challenges around finances and other things, and really sort of trying to zone in on the bits of work that we need to do to support those priorities around the leadership to care, population health, and digitalisation and clinical effectiveness, for example. And I sort of set out there a bit about the key areas of work that we're focusing on to keep going at the moment, because we have to keep going with the business as usual and everything while we're going to these wider changes. And we're just looking at ways to streamline that going as well. I'll provide more updates about that in due course. And just some few little highlights. We've also commissioned some additional dental appointments and capacity. That seems to be going well. That might come up again in our quality report later. And addressing most of the trust around prescribing the high cost drugs and other items, and we've launched the quality prescribing scheme for general practice in April as well. Again, happy to take any questions if there are any.
Thank you, Ben. Rachel, Chiefness.
I'd like two things. There will be a focus when we talk in the quality and performance report on some of the work we're doing around preventing infection and controlling hospital and healthcare acquired infections. But with that in mind, I just wanted to draw the board's attention to the success around the uptake of the spring COVID-19 vaccination campaign, and I think a real accolade to those that were involved in designing and procuring those services. So a big thank you to everybody. And there's a reference to Andy Biotic in the paper, which is the mascot that the national programme designed to reduce antimicrobial resistance has come up with. And again, really important for us to try and promote that and campaign collectively. And I think just reflecting on our story and baby Luna and the role that nurses and midwives played in her journey, that May is a special month for the midwives. Some might say every month is a special month for nurses and midwives, but delighted to have been able to join our colleagues across the system in celebrating the role that nurses and midwives play in International Day of Midwives, International Nurses Day this month.
Thank you. And Alistair, anything more to add?
Nothing that I won't cover under the subsequent agenda.
So I think on that note, happy to take questions.
It's on the research and innovation section. So really kind of really positive in terms of the connections there. I suppose it's a sort of broader question that about how, from an ICB point of view, aggregating some of the parts, because we've recognised there's been, particularly over history, a gravitational pull into the Oxford system and Oxford Academic Health Science Network. We're still the Health Innovation Oxford, but actually, there's the Buckinghamshire Health Research and Innovation Centre. There's the Centre of Excellence for Health Inequalities in Buckinghamshire. There's strategic partnership around academic kind of research and development within the Berkshire system. University of Reading, major player in terms of health and life science, in terms of health inequality research. So I suppose I'm just kind of interested in how and whether we can do more in terms of aggregating the academic and innovation opportunities across the whole of the patch. Recognising we have a powerhouse in Oxfordshire, which is really, really important. But I also think that there could be kind of a greater than some of the parts in terms of actually drawing some of the work together that's happening across the whole of the system. You've got some really fantastic institutions and partnerships delivering some real world research and outputs within health and sciences in partnership with often the health and life sciences commercial sector. Thames Valley in those areas as well.
And so it's been all joined.
I agree. I think it's a really good point, and I think through some of the national work I've been involved in recently, I was exposed to other systems and some of the work they've done, and other systems have definitely progressed that in a more tangible way in their locality. And I think there's a lot we can go after, and I wonder if we can use the next set of changes we're all going through as a way to achieve that in a more outcomes focused way, thinking about population health and thinking about how different institutions locally have expertise in different areas and how do we maximise them. So I think we should pick that up. I think it's a really good point.
It might be an ask back to the places to how can we showcase, how can we showcase back to you around some of these connections and work that we've got. I mean, George, you probably know much more about the Buckinghamshire system as well.
So I wonder if people could direct their voices towards the TV. We're having problems with the sound online.
Oh, okay.
Thank
you. Thank you for listening.
And just building on Steve's point and Anne's response, I suppose one of the things that came across from the event we attended in OUH was a desire from the Oxford academic partners, as it were, to work at a greater scale and to realise the benefits of the system population in its entirety. Not least when we think about drug trials, etc., the opportunity to generate income in the NHS. So I do think some of those historical barriers that existed, which should be a reflection of organisational culture, are starting to break down a little. But I agree entirely, Steve, that one of the strengths of this is the academic ecosystem. The challenge is realising the full potential of all the constituent parts of that ecosystem. And this is something where I think the ICB has a key role to play, both in its current guise and its revised guise, part of the changes that I've got.
And I thought maybe a route in there to your point exactly is the Thames Valley Secure Data Environment that allows us probably through healthcare now flowing into the Thames Valley SCE, kind of probably a binding force that really allows us to have a common place to bring together some of the opportunities.
I think that we will take that as an action point for our future reading. Sim and then Susan.
Just a question for Ben, if I might, from your report. Thank you, Ben. You mentioned the extra dentistry appointments, which I know residents will be really grateful for. You seem to have made some progress in that area. Can you just touch on pharmacy, the Pharmacy First initiative, and whether we're seeing any benefit or what the feedback from the pharmacist is with regard to this? Is there a positive noise coming back, or is it?
Yeah, I've had an initial meeting with the chief of the pharmacy association locally, and they're very positive about it, I think, from a pharmacy point of view. And in fact, they were talking about even going beyond. I think there's 7 off the top of my head conditions listed that it includes. And also coming down the line is pharmacists are going to be trained to be independent prescribers, the new pharmacists, I think, from next year. So again, there might be more opportunity to expand those schemes, and they definitely that fits very nicely with the agenda to push the care to the left and to the local communities. What I can't answer your question on specifically now, I think, is that impacts what evidence we've got of impact. I think we have some data showing because we know sort of how it's sort of costed up, the activity levels, but it's sort of setting that into a context of is that significant in the big picture of ED and primary care. So I think that would be a bit of work for us to do next.
Thanks. I just wanted to make 2 points. Firstly, along with what Steve said around research and innovation, I'm wondering about the interface with local authorities and their connection with businesses in particular. If that could be part of the consideration when taking that forward. And then secondly, Ben, I just wanted to ask, you mentioned about engagement with local authorities. I know you talked about that, and I wanted you to say some more about how that's actually going, because there are some issues that have been raised by sort of local authorities, for example, through the unified exec. And what's your take on how that's going?
So the meetings that I've had so far have been a combination of sort of formal meetings such as health and wellbeing boards and informal meetings. Some was in Reading last week, meeting the exec team at the Borough Council. And what struck me is that in Berkshire, where each of the 3 has different approaches. I know others are West Berkshire and Reading are looking at running workshops as well about engagement and that sort of relationship, and looking at how the health and wellbeing boards work with the local government associations and so on. So I sensing that this is also something that's in a state of flux at the moment. But it does feel a little bit fragmented at the moment and patchy, so I think that would be something we should be looking at, how we can improve that. But I'm sensing that there has been some frustration expressed about some of the length of time it's taking to get certain bits of work moving forwards, and that's something to do with also the wider context at the moment around all the changes going on and the recent organisational change at the ICB, which was obviously part of that was to improve the engagement, and then that's got stuck and going into another change period. So I think it's a sort of work in progress, probably. I'm sure that answers your question.
Thank you.
Let's move then into our current year plan, and we're over to Hannah Iqbal, Matthew Tate and Alistair Groom. Thank you very much.
Thank you. So I've spoken, we've had papers on planning in this meeting, I think, at least since November. So it felt right. We needed to close the loop and bring the final plan to the board attention today. And again, thank all our system partners, because it was very much a system endeavour this year. So I'll hand over to Alistair and Matthew to just talk about the final changes that were made in our most recent submission. The other thing I'll just say is that last year we said, in the kind of spirit of continuous improvement, we would run a planning review, and we're just about to embark on our planning review of this year's plan. So we'll be kicking that off and keep the board abreast of that. Thank you.
Alistair, do you want to go first?
Yes, I don't think I've an awful lot to add to the fact that the plan was submitted as a balanced financial plan. There are within, sorry, how am I looking at? There are within the plan quite substantial cost improvement plans, a total of £299 million in each of the provider organisations, as well as a £24 million stretch. That's challenging, but it's not out of line with what is nationally the position. The revision in between the 27th of March submission and the 30th of April submission allowed organisations to improve their SIPs and cost improvement plans, and so that opportunity was taken. There were also a couple of corrections made to individual providers' returns. So it was a bit of a sort of tidying up housekeeping resubmission as far as this system was concerned. We're now, in terms of planning, moving forwards to put the plans into contract, and we're working with the provider organisations, both in system and shortly out of system and independent sector, to put those into contract. The form of the new national contract hasn't yet been finalised, but we are expecting to have levers that will enable us to control activity in line with our financial affordability, in particular with agreeing indicative activity plans, which the new contract, we are hoping, will allow us to enforce those plans if we can't manage to agree them by mutual agreement. We're then, in parallel with that, setting up contract oversight and contract management meetings with the individual provider organisations. So we're sort of translating this from a planning phase into a management of the 25-26 plan phase. Happy to take it. Sorry, Matthew.
Yes, well, I'll add 2 or 3 points. So in terms of our performance plan for next year, there's just a couple of areas that remain non-compliant with national ambition, but we should note that from our previous submission, OUH did improve their trajectory around aiming to become compliant with the national target at the end of the year. 2 areas where we've got further discussions still taking place and still a bit of a debate about whether the plan will be accepted is RBFT delivery against 18 weeks, which is at 80%, which is broadly consistent with present performance, but doesn't show a 5% increase. So have a discussion with the region team and with Don at the RBFT as Chief Operating Officer. And apologies, I didn't introduce myself. So I'm Matthew Tate, I'm the Chief Delivery Officer for the ICB. So we're having ongoing discussions about some of the reasons behind that, which are related to the size of the backlog and the level of demand in a certain number of high volume specialties. And therefore there is a financial constraint on the ability to deliver that target, which is also enhanced by the level of data quality work taking place at the Royal Berkshire, which will reduce the overall waiting list and therefore makes the calculation challenging. So those discussions are ongoing with the region to understand some of the operational challenges facing the trust. And then the other area of non-compliance is at Oxford, which is against the 62-day cancer standard, where the national ambition was to get to 75%. and the Oxford plan is around 71.1%. So again, we've had sort of check and challenge sessions with the region to understand the demand, and as I'll mention later in the performance report, we are going into tiering for cancer, which is a national intervention model which will support all trusts around their cancer performance. The view of the team at Oxford that at this moment enables some of this outcome.
Comments and questions. The plan has had significant discussion and subcommittee scrutiny, and just want to echo Hannah's comments about the helpful way in which we have reached this. It is a stretching plan, everybody involved, and pleased to see that the monitoring of that is already underway and in our sites, so that we really are focused on not slipping early in terms of those areas. Good. Let's move then to George. Do you want to? Let's move then to our month 11, month 12, and close off with the year. And if I could again turn to Matthew, Alistair, Rachel, and Ben.
Should we start with finance? Yeah.
Sorry, so month 12 finance. Yes, right, okay. So month 12, sorry, I'm Alistair Groom, Chief Finance Officer in brackets interim. The month 12 ICB and system packs are included in the papers in detail. I'll just give a quick overview. Overall, while the final month 12 position, looking at the whole year in the round, is just short of £16 million deficit, this is actually very substantially less than the trajectories that had been indicated during the year. So while it isn't good to be elevated, it's actually quite a positive outcome, which reflects a lot of work all round in the ICB and in the providers that, compared to other national systems, we should be pleased with. Within that final year-end number, the ICB actually in the last month moved some funds around to enable cash to be released to providers. So if you look at our ICB numbers on a month-on-month basis, they actually look a bit curious, but that's why, because basically we redistributed funds so that cash went with providers to providers who needed it more than the ICB needed cash at that time. Overall, just looking very briefly at each organisation for the year, the ICB had pressures in mental health, Section 117 and other complex patients, high-cost drugs and unbundled radiology. OUH had an adverse position due to underachievement, in particular of pay slips. RBFT was unable to cut costs to reflect a contract reduction and had overspends in non-pay and some pay slips underachieving. OHFT was better than planned due to cost control. BHFT, Berkshire Healthcare Foundation Trust, was better due to a payment which hadn't been expected of 23-24 elective recovery funding money. Otherwise, they were all on plan. Buckinghamshire Healthcare Trust was on plan overall, but there's quite a lot of complex ups and downs within that. As I've said, there's two comprehensive packs there, the ICB and the system, and also some detailed workforce analysis. I'm happy to take any questions. If I can give a sort of flash update, moving, because we're now in May, so April's finished. We're now into the 25-26 year. We've had month one numbers. Normally, the finance teams don't do month one numbers, but NHS England are wanting to keep a close eye on the situation, so they've asked for a month one return. I'm pleased to say that all organisations in the system are reporting to plan in month one, in brackets subject to final governance being completed. So that's all I wanted to say on that. Happy to take any questions.
Let's pause then for any questions.
Thanks very much. So in terms of the, you just articulated, it's good that there's a reduced deficit. That's good to hear. And yeah, the reasons that you've given for that reduced deficit. I'm interested in what's the learning, or is there any learning that you've taken from that that you're now applying into this financial year 25-26?
So I think that in essence, we've done an awful lot of financial housekeeping, looking at where we're spending money within the ICB, and we've significantly increased the capacity of the finance team, and so we're more on top of that language. We are on top of the numbers better than we were this time last year. We went through, with the support of NHS England, quite a challenge process through the investigation and intervention regime, and we will carry forward some of those learnings into 25-26. The principal bit of that, I think, is through the establishment of the indicative activity plans with the providers, and the contract oversight that we're going to do with that, which will be probably resource intensive, and it is down in the weeds for this meeting, but it is very important that is done, so that we are getting the activity that we're paying for, and that we're only paying for the things that we should be paying for. Working collaboratively, obviously, with system providers on that. So I think the main lesson is tighter plan, and then tighter delivery.
Yeah, I mean, it's not for Alistair. I think it's a general point building on Alistair's kind of summary, that positive in terms of where we've kind of got to at year end, and I think your point about coming into this year as well in terms of the planning work that Hannah alluded to. And I think it's important to log the work the ICB is doing actually with us, that there is a cash challenge in the system amongst a number of organisations which actually has real solvency issues. And that's kind of being worked on with the support of the ICB, and it's really material. So it's material to the point of probably the end of this first quarter, beginning of the next quarter, in terms of material solvency in some parts of the system. So I think it's just important that that's kind of recognised as an important facet of, yes, how we ended the year and how we come into this next year, but we've got some real challenges that we're trying to work through together at the moment.
Agreed. So yes, recognise, and we're as initiated by Nikki, your CFO, we're now meeting weekly on a Thursday morning with the acutes to discuss the cash situation, and so we're monitoring it very actively. We understand that there may be some guidance coming down from the centre in terms of central money, but the bottom line seems to be that there won't be any cash coming down. So we need to continue to work within system and to control expenditure, and it's going to be challenging, but working collaboratively and openly on it, and I'm hopeful that we can avoid major challenges. We did have a system CEO's discussion on it at the end of April, and I think we have a way forward on some of those matters.
It's probably just to recognise, sorry, that one of the potential consequences of how we might have to manage that could be potentially the ability of the system to spend its generated capital, which is slightly perverse given the challenges we've got in our physical estate, equipment and digital capability. But there's a relationship there, isn't there? So that we're going to have to go work through. So it's just probably to reflect that, and that's something we're going to have to track as an ICB and as a system partners throughout the year.
Yeah, agreed.
yes, it's an important recognition that the operating context has changed in terms of how that will be managed, how it can be managed, and therefore the diligence we are collectively looking at those factors that make cash flow possible and anticipatable are really important in all our system partners. Saqib.
Thank you, Saqib Ali, Audit Chair, and also representing Tim Nolan, the SPC Chair. There's a question I noticed in the plan that AUH and RBFT both have, I can't remember the number off the top of my head, I think it was 70 or 80% high risk in their CIP. And so I was wondering how they had fared in April, if any of that CIP had been intended to be delivered in April, because otherwise, obviously, it's going to have a knock-on on their cash position as well over the course of the year and achieving our targets. Obviously, until last month, we were having the financial outturn meetings, which overview meetings, which I guess, if they're not continuing, how we have that scrutiny going forwards.
Thank you, Saqib. With regard to the specific month-on-month performance, I haven't gone through the detail myself yet. We, other than to flag, they say they're reported to plan. SIPs by most providers and probably the ICB won't be front-end loaded. They will be loaded more towards the back end. We are working with NHS England, who we understand are going to set up a fortnightly SIPs return. And so we will review that ourselves as a system before it goes up to NHS England. So we'll be looking at organisation SIPs and their maturity every 2 weeks, and we will also take an output of that to it'll come into this board and also to the system board.
Yes, thank you. And as Alistair indicated, the end of year financial position was a good deal better than we had feared, anticipated. And in no small part, that's a consequence of the turnaround approach which Alistair led. So I'm very grateful to him and the team for that. But despite best endeavours, we did end the year in deficit. And what's very clear this year is there is no more money. So we as a system and providers within our system need to break even. So it just reinforces the need for us to start leading it well and to really focus on implementing the plan, which I think we've all recognised is an ambitious one. But there is no more money available centrally to bail us out if we're unable to do that.
Let me move us then to our performance and quality report and over to that.
Great. I'll pick up on the colleagues, then make a Chief Delivery Officer. And as usual, I should pick out a few from the service areas in terms of so, as Nick said, we have our annual review, so we did a bit of year reflection. So I'll perhaps ask board members to have a quick look at the graphs. I think it gives a nice look. So on page 118 of 222, those who if you look at UEC, you see it's probably we certainly had a much better winter than previous year in terms of performance against the 4-hour target, and it probably is just about on a trajectory. But it is a mixed picture. What is clear, we didn't make the ambition of 78% as a system at the end of March, and we ended on 74.7%, and only one of the 3 trusts, which was Buckinghamshire Healthcare Trust, got to that 78%. But overall, we were better than last year. And there have been a couple of specific challenges that we've got to focus on. So halfway through last year, we extended the Reading Urgent Care Centre with a new model based at RBFT. I think it's fair to say that hasn't had the impact on the 4-hour number we were hoping for, and the trusts have now proactively reached out to regional advisors for additional insight into the challenges they're facing. So that's really positive. Oxford numbers are the only trust that's got worse compared to last year, and they are looking at the reasons for that. Demand increase, the trust are trying to cope with it, but also they are still part way from additional overnight care, in response to the A&E forward. And I would say that both the RBFT and Oxford University Hospital Trust have bid and received approved in principle for additional capital for the urgent care pathway going into the new year, which is really good. We are expecting Joe's next point about winter planning. We were expecting on Monday, so any day now, a new care plans for next year. I would just remind the board that actually on a number of metrics in the urgent emergency care pathway, we are best in class. Acute performance, which is our ambulance performance, has really improved dramatically during the course of the year. We are starting on the target, and as our meeting probably the most, we remain the best for discharge numbers across South East and the 12-hour waits. The emergency departments from some of the best across the South East. In terms of elective, again, it's good to look at the graph, and this one you will see that overall we are getting on top of the 65-week ones, and you can see how that's come down gradually over the last year and a half. So board members will be aware of the ambition to remove 65 weeks by the end of September and the challenges that Oxford have had around that, and we continue to work with Oxford over the last couple of months to get that number at the end of March as low as possible. You'll see in the report, which is February numbers, that 55, subject to final validation for the next board. Final number was around 65. So a real push with support from all trusts across Bob to try and get that number as low as possible. So that's been helpful. As a result of that work going into the new year, Oxford have now formally been removed from the tier one elective care as we go into the new year. And finally, cancer. Again, I think the on page 121 is really interesting because it shows a couple of things. It shows that actually on 62-day, which is the metric that we've been struggling on as a focus for this, you can see actually, look, last year, and I think I remember being very pleased about the improvement in cancer performance at the end of last year. There was an improvement as we came up to the end of March. This year we haven't had that improvement. Indeed, we've had a drop during the last couple of months in terms of our overall system performance. And even going into February, which the numbers in this report, we've seen a drop from Denver. So the report highlights some of the issues around that, which are often capacity related, staffing related, and demand related. It's really a combination of a few of those, and there's some diagnostic issues as well. But I've already mentioned the result of that overall, we have been placed into tiering as a system. Now, tiering as a system is unusual. Actually, it tends to be a trust-specific inspection, and I think it's helpful in one sense in that it allows us to work very closely with the Thames Valley Cancer Alliance and really working hard on system solutions. But I expect you to look at the numbers by individual trusts, not just because the chief executive of RBFT happens to be here. The RBFT probably would not go into tier on its own. I think given some of the complexities across the system, the view is that it might be helpful to do that as a system. Now, on balance, I think that probably is a helpful intervention. And we've yet to hear if we will get more funding. Sometimes you do get additional funding, flexibility for tiering, but I think our opportunity is going to work closely with the Cancer Alliance as their staff to really focus on these challenging pathways to improve performance. That's all I wanted to say. So I'll hand to Rachel next and then Kate.
Thank you. So afternoon, Rachel Corser, Chief Nursing Officer here at the ICB. A couple of things just to flag. There's a reference in the performance and quality report around the work that we are doing with our colleagues at specialised commissioning service at regional level, who commission services supporting the health and justice services, which in here reference sexual assault referral centre. And locally there have been some concerns raised by some of our practitioners around the national specification that has been commissioned. And just to reassure the board of the actions that they are taking and working on a weekly basis with our commissioning colleagues to look at what we can do locally to address some of those concerns that have been playing out in order to mitigate some of the gaps that we have identified in that commission service. And a big thank you to our colleagues at the Health and Justice team and nationally for listening to those concerns and working alongside us to mitigate those risks. From a quality and safety point of view, just a couple of things to flag. So it's the time of year where we work with all our providers in the trust, but also our smaller services, signing with their quality accounts, and really looking forward to seeing a combination of the quality accounts coming through and the key themes as we plan our priorities going into 25-26. There's reference in the report of us pending publication of the joint targeted area inspection of domestic violence support services in the Reading local area, and that has now been published, and there are a number of priority actions that we are working with our colleagues across the multi-agency partners on, and there's more detail in that in the Chief Exec and Chief's report for board colleagues. All of our providers have now had their paediatric audiology quality assurance visits, and I've reported to the board previously the work that's going on nationally to look at some of those improvements that are required. And 2 of the 3 providers are working with us on improvements around their paediatric audiology service, and we are grateful to the colleagues at the Royal Berks for supporting some of the subject matter expertise in that regard and working through those improvements collectively. You'll see in here the work that we're doing around maternity and neonatal services. I think just one area to flag for the board is the continued rise in the demand for cesarean section, which does play out in an impact on our demand on theatre and elective availability for services. So working with colleagues on how we can look to review that demand and that activity so that we can continue to meet demand as it grows in the and then lastly, just to draw the board's attention to the work that we're doing around infection prevention and control. And nationally, we are seeing rises in healthcare associated and healthcare acquired infections. And we're seeing that across all of the infections that you can see listed here. We aren't seeing the same rise that everyone is seeing nationally, but just to flag a couple of things that I want the board to be made aware of. So I referenced in the Chief's report the work that we're doing around Candy Biotic, our mascot, to raise awareness around good use of antimicrobial prescribing. And that's really important. And you'll see again in the report the work that we've done with our public in trying to raise awareness of appropriate use of antibiotics. And the use of antibiotics is one of the biggest factors in driving infections, particularly in the Clostridium difficile infection. And it's great to see that the impact of the quademic that we've known to love over winter around flu, COVID, the respiratory syncytial virus and norovirus is starting to calm, and actually the numbers of beds closed across all of our health and care system is reducing as a result of the excellent campaign that we've got in place around vaccination for our local community. They're all the main things I wanted to flag. Thank you.
Thanks, everybody. Chief Medical Officer at ICB. So just looking at slide 10, when we've got the primary care access data, we're seeing the sort of usual seasonal variation with more urgent care appointments over winter, and then that sort of moves into a planned care phase. That's the most precious drop off, and people are booked longer in advance and so on. So we see that sort of happening every year. That being said, if you look back over to this time last year, there's been a significant improvement in public user access to the general person time and with Oxford West, but Oxfordshire has dipped very slightly by about %. So looking at that, and it's maybe more that the other two are sort of caught up with Oxfordshire. And it's interesting that it links to, because there's an interplay between the ED performance and primary care access in both directions, as we know. And just supported that Oxfordshire did have a slightly harder winter from an ED performance point of view. So we'll be following that up and sort of trying to work out when those variations becoming trends and things that we can on. The other bit, just about similar to earlier, actually, but just remember that the pharmacy burst data is in my slides 120,000 sort of consultations between last year, could be this year. Technically that scheme, which is a significant benefit to general practices. I think what's the harder to tease out from that is then exactly, are these people that then they can go on to use other services? So that's the next stage of our data evolution to answer those questions. And then at the end of that, we've got the dental slide. I was just going to draw attention to that. It's a positive trend over the past year with dental access. More plans in the pipeline around urgent dental care, which we're anticipating that continuing.
And just add something on sort of the process of we're at the end of the year. So every year the team have a look at a bit of a refresh of performance reporting. So Ben Gatlin and my team is going through that process at the moment. So if there are any particular feedback around the report, how it's presented, or indeed areas it covers, then please, board members, let me know, and we can feed that into the review. It's always a balance between how much detail, where to focus attention, but I think it was mentioned last morning, we might need to refresh some elements and give us some of the change in nature of national targets.
Sandra and Steve. Thank you, Priya. Since Kabatza, non-exec director. Apologies for not introducing myself before. Just may I ask about children learning disabilities and autism? Would that be that's Matthew. And I just noticed the February figure, slight improvement in adult inpatients, but not in children's services. And I know we've struggled with that performance for some time, and I know the list of actions that we have in play to mitigate. But what I'm trying to understand is, have you found that those actions have made a difference to performance in adult? Is it that they just started to come into play? Or are there other things that we have to do in order to secure performance in children's? Because it's an area that we struggle with, haven't we? And I can see the risks. You've noticed the risks, noted the risks around how we transition and being very careful what we've got with that. So can you just help us with a little bit, give us some assurance around it?
Yeah, if you're okay, so if you're happy for me to take that away and do a note, I think you'd be better informed if I could talk to the team about it in more detail. That's okay, otherwise I would be probably only reflecting the team. So happy to take away and do a note out of the members seeing more detail.
Thank you. Sandra Barnett, Chief People Officer for the ICB. The workforce elements of what we report in performance in finance, etc., are kind of woven through the report. So I just thought it might be useful to highlight some of that to the board. So we finished the year 1.25% above plan from a pay bill perspective, which, when you think of the complexity of the 40,000 staff that we have to plan for, is quite a favourable position. However, that equates to £30 million off plan. So I think it's just about making sure that's kind of put in the context and really making sure that we learn from that. What we noted last year was we actually started off plan. So we've done quite a bit of work with trusts about saying how can we improve that position so we're not constantly kind of chasing our tail in that space. So lots of work going on this year. I know trusts that we've been working really hard through the various situations of what the plans will be. However, all trusts have a challenging picture to deliver to their, obviously financially and to the workforce plans that they've got in place. So it's just about noting that.
Hi, Stephen Manus, Chief Executive Royal Berks Foundation Trust and Trust and Partner Member. I think it's a general question, but maybe from Ben and George, really. So is there anything that collectively we can do as a system to support getting maybe the maximum share or the maximum utility from the primary care utilisation and modernisation fund in terms of primary care estate? Because I can imagine that with the primary care leadership and with the ICB, you're focused on that. But I wonder whether, so looking at Grant as well, there is something about our system partners across the piece could lean into either data where we've got particular challenges in terms of primary care access that we see coming through maybe our emergency departments, or where we can think about our estate more widely in terms of one public estate. Is there something we can do more collectively to really get the biggest opportunity from maybe proposals and access to the fund?
Yes.
I think the answer to that, yes, and I think that would be welcome. Only yesterday I was catching up with Julie Dandridge, who's our primary care estates lead, and it's quite apparent to me, sort of getting to the grips with all of this as a new member of the board, that there's huge overlap between what community needs, what primary care needs, and the opportunities to sort of have a much more strategic approach to it, really. And actually then marrying that up with the data around hotspots and operational performance would be another layer to that, which would be really useful, I think. And yeah, I do think that would be an area where we could take forward. And I think actually local authority partners, I was going to add into that piece as well, in terms of looking at the estate and the infrastructure in a much more joined up way.
George.
So I completely agree with that. Actually, where I think the best opportunity comes is going to be around S106 and contributions. So if I give you a little anecdote, and then where I think we can deal with this. So S106 contribution, you need to have worked up plans to be able to implement. So it's been really difficult for GP practices to do that. They don't have the expertise or knowledge. And the ICB, I must say, have done a fantastic job in starting to support practices in that where there wasn't really that support before. So first of all, sort of credit to Ben and Rachel as predecessor on that. The anecdote is that there's a big development going up in my patch, which my surgery put in a comment around S106 monies. Against that, BHT put in a massive pack of shiny sort of pitch for that same S106 money. And what it really struck me at that moment was we're trying to get the same money here for healthcare independently without coordinating. And actually, I know the board well at BHT, and I know that they recognise that, supporting primary care estates will support trust performance. So actually, I think the key here is looking at how we go in for those S106 development contributions and making sure that there is a coordination between acute community mental health and primary care. And actually, I think the ICB's role in that might be to convene that. And that's where I think the best opportunity is. And given the ICB are doing great work now in supporting primary care in the S106 sort of bidding process, and there's tangible outputs to that sustainability of success. I think that's the next step that we should be prioritizing.
So, sorry, I didn't say before, I'm Susan Parsonage, partner member, local authorities, chief executive at Woking Borough Council. So when you talk about section 106, I'm presuming that you're referring to the development contributions coming through the local authorities. So I think that, it's really, really key to engage with local authorities, because I think it's a real opportunity to shape the place. So that's why it's important to actually have that, come together around that. So I think that convening, coming together is pivotal, because there are often a number of calls for that, and the earlier the conversation in terms of section 106, the better, because the planning is often done really well in advance. But I think it's a really, really, yes, it's a real opportunity there.
That is so helpful. So you're giving bankers we are always keen to find the way that can make the most immediate difference. And working together in this way in relation to 106 is one of those tangible ingredients. Alongside that, we know that we have backlog maintenance plans across our whole system, and also states that cannot continue to exist and be utilised because the cost of the maintenance for that estate is probably outweighing its for life, and our options are much greater if we can look at that collectively across, as you say, Steve, as one state. And having our local government leadership in sort of what those options might be would be really helpful.
Yeah, so on that, I think that there's a real link between, like say, existing estates, stuff that's going to get built in the future, and then thinking about the place shaping and the neighbourhood working. So we're going to talk about neighbourhood later on in the agenda. I think it really, there's a real opportunity there.
Yeah, just a couple of thoughts. So the whole issue of Section 106 monies is probably the second most common issue that is escalated to me by our MPs. ADHD and autism assessments and treatment being the top issue. But it also highlights, so I don't think as a board we spent a lot of time thinking about our strategic approach to estates in general. I just wonder whether that's something we could factor into a future board development session. So there's a lot of good work in the primary care team, Ben's leading. We've also had a report, just sort of state of the nation, it's just been received, pulled together by our former CFO. So we've got some materials I think which should help inform productive conversations. And we think about it, the board plan.
Sure.
Sorry, I didn't introduce myself. I'm George Kemp. I'm a GP at Department of Primary Medical Services. I do want to just actually make note that the Utilisation Modernisation Fund, the turnaround was ridiculous. And actually, I think we should congratulate Ben's team and the specific members who did actually manage to get a huge number of successful bids across all 3 places in Bob. So I think that's a huge credit to them. At a time when they were already under a lot of pressure with the reorganisation. So actually, I just want to make a note of that.
Thanks a lot.
Well, I was just going to say, so there are examples that we are doing this. Essentially, I was thinking, probably aware that the White Horse Council is, and the still money from there is being used to develop Wantage Community Hospital for community services, and in fact there is a primary care element to that as well. So if there are examples of happening, but it's not happening in this sort of strategic comprehensive way.
So what are the opportunities are not utilised and captured? Thank you very much, everybody. Any other questions on any other element of performance, quality finance? Thank you. We are now going to have a short comfort break and come back to our future changing system landscape and the future of our ICB. Thank you very much, everybody. Could I ask everybody to reconvene at 3:30? I need us to restart, please. Very much. Lovely, welcome back everybody. And we are going to start our second part of the session with our building for the future. And this is the changing system landscape and future role of ICBs. We're going to be including the model ICB blueprint and also working across the South East region. So thank you very much, and I'm going to hand over to Henry.
Thank you, Priya. So we wanted to bring to the board's attention today something that would be we're all aware of, given the changing role of ICBs within the changing national architecture of the NHS. So ahead of the publication of the 10-year health plan, which we now expect in end of June or early July, we're seeing a real reshaping and redesign of how the national, the regional and the system architecture of the NHS works. So on the 13th of March, the government announced the abolition of NHS England and a streamlining and refocusing of integrated care wards, including a reduction of ICB costs. At the time, that was described as an average of 50%. And then in April, the new CEO of NHS England, Jim Mackey, wrote to ICB and provider leaders outlining an agenda for reform. And that letter included reference to a document called the Model ICB, which we now have in the paper today. And the Model ICB blueprint was jointly developed by NHS England and ICB leaders, including myself, and sets out a vision for how ICBs may work within a reshaped system architecture to deliver the 10-year health plan. So this is the beginning, I think, of a big change programme at multiple levels of the system, with a lot of complexity and a lot of impact on our population, but also crucially our staff. So what we wanted to just draw attention to today is the refocusing of ICBs on strategic commissioning, which is something we've talked about within the board before. A real focus on aligning the way ICBs are set up and structured to deliver 4 core activities that will enable the improvement of population health. And those are understanding local context, developing population health strategy, and then using the resources that ICBs have. So for us, £3.6 billion, and making sure that we're maximising the value we get from those resources to improve population. So I think this is going to be an area where we probably want to keep updates of each board meeting, given it's a fastly changing landscape. And the other element of that we wanted to bring today relate to the working of ICBs across greater footprints as they come together to deliver functions at scale. So Nick may want to come in and talk about some of the work that's been in train across the South East region, where ICBs are coming together to think about commissioning at scale in areas such as ambulance and specialised commissioning, but also now, what are the core functions that we could deliver more efficiently for our population in terms of GPIT and other aspects. So really it's for noting and discussion, and just the fact that as a board we need to keep our eyes on the changing system landscape and make sure that we are responding to it and bringing our people with us. Thank you.
Yes, just in relation to the model ICB blueprint, I just wondered whether as a board we need to agree our governance in relation to signing off the plan we need to submit to regional team NHS England at the end of this month. We received a template last week, and the template needs to be populated and outline how we as an organisation will be able to reduce our running costs to live within of £18.76 per population by the end of the third quarter of this financial year. There's a lot of work being trained, being led by Sandra Grant, who's carrying our transition programme board. We pulled together a draft plan, but it's some way off the finished article, and we're somewhere off finishing populating the template. So what I propose to board colleagues and the intent is that the board primary delegated authority to sign.
And can I take that point first? Are we content? I think that's a very sensible way forward. We're going to be moving at some pace in relation to making sure that content information clear format look at the shaping of the new functions for the ICB as we go forward, and with a population cost of £18.76 as our base unit of pension. Can I ask for comments and questions in relation to the delegation as the agreement? Thank you. And then can I open for comments and questions around the model ICB and also any of the elements we're going to come through about working at scale across the southeast?
Please, thank you. So in terms of the question about the blueprint, just thinking about local authorities, and they'll have a number of questions about it. And I think we need to think how the engagement will take place with local authorities during the implementation of this. Maybe you're interested on the answers now, but that will need to be on consideration.
So last week I attended the CEO call with Nick, where we briefed local authorities, chief executives who were able to come on the blueprint. But as I say, and I think we're going to meet tomorrow, aren't we, to discuss that point. But we need to now start. I think it is very much a blueprint, and it's quite clear it was pulled together quite quickly. And there's a lot of detail that needs working out. So I think we need to now kick off a programme of co-development in terms of what are the design principles across the system, really, that takes this and tests it and works out which bits of it we want to take forward in our system, which bits don't really land, and which bits we might want to refine further.
No, I was going to say, would it be helpful to say a couple of things regarding the terms of reference in the pack? So working across the region approach. So as colleagues will be aware, there is quite a strong history of inter-ICB collaboration. As a group of ICB chief executives, we've now been meeting informally for a number of months, looking at areas where it makes sense for us to work in partnership, particularly the delegation of specialised commissioning ambulance services, and also IT matters, now looking at things like EPRR, emergency planning, response, etc. And it's been felt for some time that we need to try and formalise this arrangement, so that the meeting has been a sort of shadow meeting. And the proposal is for all ICB boards to agree to these terms of reference that are today. In part because we need to have some formal governance in place in relation to the delegation of specialised commissioning. As you've seen, there are also terms of reference for the ICB specialised commissioning subcommittee. The proposal being that it's up to the ICB CA's joint committee and then feed into the ICB. So our governance leads have been closely involved in the development of these terms of reference. And it's taken us quite some time to get here, in part because we'll try and do things in lockstep with the 6 systems moving as well. So the ask of the board today is for approval of 2 sets of terms of reference.
Any comments or questions? I think one of the important things for every board is to understand its responsibilities in relation to partnership working, joint working, and this is the opportunity to work at scale to get the best for populations by working at certain scales. So we retain as a board our obligations and responsibilities in relation to all those things that we will do at scale because they are part of our partnership agreement. So we will still have the elements that allow us to know that the joint endeavour is working well and meeting the needs of our populations.
Yeah, just an observation following your comment here. This is this is a pretty significant time for the NHS with the changes, and just the recognition that from a capacity point of view and let's say pressure and challenges, they mustn't be underestimated. So I think it was really useful, Hannah, as we go through the process of update to this board, that somehow we can keep our public, the people that use our services, up to date as much as we can, in a sensible way, so they at least know what's happening. Having introduced them this today at the public board, I think it would be remiss of us not to just give an update as we can, as we do the work, as we realise that we don't have all the answers, and also give assurance that we're managing that transition really well, as well as we can do, because there are risks. And it's really important that we're all in this together. So we need the public to feed back to us if they, see things that aren't working in the same way. We need to be honest with how this is working and slow things down if it's not. So I just think there needs to be a decent contract.
I think that's right. And also, actually, it's one of the themes of the document, which is that if the model ICB is implemented in a successful way, one of the ways you would know is that evaluation, rigorous evaluation, whether it's real-time kind of data analysis or whether it's kind of deliberative design with populations and users. I think the NHS hasn't been great at it, and I sit next to these, and I'm sure local authority can be better, but there's also a lot of kind of design thinking. There's different ways of doing it that we can embrace now, and I think will be one of the tests of whether this change is worth making.
Good. Okay, shall I move us then to our next session, which is developing our foundation and neighbourhood.
Are we approving?
Oh, I'm so sorry. I should have asked formally. So are we approving our term spring?
Sorry, Chair, I don't think it should have been two things, just the one of the joint committee.
Yeah.
Yes.
So just, maybe it's not very here, but I do think is, sorry, Graham McDonald, also to help me as the mental health party member. It just feels better, wide-ranging and slightly idiosyncratic part of it, sort of to talk about review of all mental health services. In section 5E. It's just, I don't know, it's not for us to unpack that here. Maybe if you could take that in for that to maybe get clearer and so on. It's a bit like, let's read everything. And see, I suppose there's a point to this, and it's that specific things like Nick.
It's fair to say, in recent conversations, we've not touched on mental health services that way. So, yes.
I know this is probably a bit historical. I just think if we do something great,
yes.
Feed that back. Thank you.
I think that's a really important point, isn't it? Because the public will want to have confidence that services that are running well and are continuing to run in the first instance, whilst the transformation that we are all talking about across all lines of and will evolve and will change, but not that we will look at things for the sake of looking at them, but there will be a timing prioritisation, and that will feed in and make sure that we get that reflection. And my apologies, I should have asked for our confirmation, please, that we are supporting and approving the terms of reference for the joint work. Thank you. Good. Let's move then to neighbourhood health.
Thanks very much. Yes, we've put forward a paper summarising our sort of planning around the neighbourhood health programme. I'll just sort of read a quick summary of that, and then we're very happy to take questions. Stepping back from this, the ultimate aim of all of this in developing the neighbourhoods is to bring together the health and care services that we provide as NHS and statutory partners, but also with voluntary sector and other partners and community representatives at a local level to create healthier communities. And that's really thinking about helping people to live healthier, more active and independent lives for longer. And we know from the population health data that that's a real imperative really for a sustainable future health and care system. We also, as part of that, want to increase people's ability and their agency to manage their own health. So we're more focused on prevention while improving their experience of accessing and using care in that local context when they actually need to. The 25-26 planning guidance and associated neighbourhood health guidelines from NHS England has asked ICBs to work towards the delivery of this model based on 6 areas. And these areas span across not only the ICB's team, but also a range of partners in the system as well, in terms of our interest in this. So the first one's population health management. So that's about setting up systems around the data sets for population health outcomes, risk stratification, strategic resource allocation. We've obviously done a lot of this on power work and other sort of work looking at the health of our populations. Modern general practice is the next one. This is about a modern general practice model, which involves streamlining access and making it easier for patients to connect with the most appropriate healthcare professional or service when they need to. There's part around standardised community health, so that's working with community health providers, trusts and other local partners around creating that standardised offer for patients around community health services. And we do know that within our patch that bulk that does vary a little bit from place to place. Neighbourhood multidisciplinary teams, so these are teams within neighbourhoods that are sort of focusing around particular health needs. So the commonest ones we've got around frailty or people with flexibility, mobility, and then trying to find a more effective way to support those patients outside of hospital settings, particularly. There's the integrated intermediate care, home first approach. This is about getting people back home from hospital admissions and we enable as quickly as possible. And urgent care as well is another strand of that. So it's quite a wide range, really. So the paper we've put forward provides an update to the board on how that agenda is currently progressing across board, and also proposes that we establish a board system neighbourhood programme, and we've set out the key role and the function of the programme in the paper. Part of the programme's role will be to convene the 3 places to share and cascade best practice and the lessons learned so far, to agree that a common vision, such as answering questions like what we actually mean by neighbourhood, and fundamental things there that hours of discussion at the moment, and also serve as a coordination point for stakeholder communication, co-production and engagement, building ready on the work in those areas that we've done in the places, which are also summarised in the paper. So we're proposing to establish a programme board to coordinate that work, and that will include our ICB teams, but as well our neighbourhood partners and stakeholders, and that will also include teams working on the current pilot projects. So this will have a cross-system membership, and the idea really is to provide a sort of overlaying light touch level of coordination and support consistency, so that we can collectively shape and articulate a universal offer to residents, while also enabling providers and partners to get on with leading into delivering neighbourhood health in their own places in that context, because that's important as well. Another key role will be to clarify and coordinate the engagement with communities and the public, given the wide range of organisations and stakeholders who have an interest in neighbourhood health. And on that topic, we've received a question for today from a member of the public, Mike Atkins, who's asked a number of questions about the neighbourhoods in Buckinghamshire. How are they being defined? What engagement was undertaken with local people and communities in designated neighbourhoods? And will those details be published on the Buckingham Place part of the ICB website? So in considering those questions, I think it's important to note that the neighbourhoods are not something that anything that all the ICB is prescribed from the top down, but local collaborations that are evolving over time as their purpose and their function is developing and getting defined. Most of the neighbourhood projects underway in Board to date have been based around primary care networks and reflect practice population boundaries, although this may evolve as the next stage of development happens, because increasingly that's going to include more community partners, voluntary sector, local authorities, other system partners, as we move into that sort of wider preventative realm. We do actually have a slide that sets out the current neighbourhood fees, so it'll be easier for me, I think, to send some of this out rather than describe it all here. I've been advised by the Buckinghamshire Place team that 2 discussions on neighbourhood development have been held at the Patient Participation Steering Group Buckinghamshire to seek input and ideas on how to best engage with local residents, and that more of those sessions are planned. And a number of neighbourhood pilots were run last year, not only in Buckinghamshire but elsewhere across Bob. And members of PPGs have reflected the positive engagement in those pilots in many cases. And I think there have been a relatively close link in the North Buckinghamshire that's been successful. These are only steps, though, and the key aim of the neighbourhood programme will be to develop that consistent model for residents within their local context. And also, as part of that, make sure we have got an effective approach for local engagement or co-production. And I imagine that expanding to use other sort of roles like community researchers, community leaders, communities of practice, and bring that sort of wider way of getting engagement and co-production going. Healthwatch is also very involved, working with us on this aspect. And neighbourhood development is being reviewed and discussed frequently at local authority, health and wellbeing, and in mosques and so on. So there are lots of opportunities. I think this is about coming back together and getting clearer. So to summarise, the board's asked to note the progress that's already been made by the place teams in particular, who've been driving the multidisciplinary program, working for a number of years now, and also to agree direction travel in this system neighbourhood programme to support neighbourhood working as it's implemented further and developed.
Thank you very much, Ben. I'm going to bring in Grant, Susan, George, and Rachel.
Thank you, Ben. So I think there's no secret in that the 10-year plan central line will be the health services. So no secret in that it will be pretty much the only story about. So I think it's really, really important. I think also it's really, really important looking at this summary of what's going on currently. Somebody does hold the ring in this, and I don't think light touch is maybe quite the right thing. I think politically sensitive is the right one, but somebody needs to help have an understanding of what variation there is and why, because the variation is quite profound, and I think that therefore there's a lot of learning for each area. But we don't want free meals, do we? We want a sort of thoroughbred or free, you know what I mean? It just feels you could end up in things that are different. So I feel quite strongly about this personally, just because I think it's opportunity that great to do the things that I think a lot of parents are worried about what will happen to plays. Well, this will be plays, and it'll make plays work really well, actually. So we have a local place, Homeless Neighbourhood. I think there is issues about language as well. I don't know what 10-year plan will play out, but for the neighbourhood health services, sort of detracting neighbourhood health and social care services, but we need to find the right language for that, don't we, locally? I would fully support it, but I would also support a real challenge to variation as we go through this, but learning language and variation. And that's in a clear and strong way. It's not about saying one thing's right or wrong, but we try to sort of explain the difference. Now you're correct with my suggestion, but sorry, Chair, it's important to set off in this in the right route, because this will be the story of the 10-year plan publishment.
Vital. And one of the things that we all do in our organisations is to help people to engage with data about variation from the perspective of what if it is true, rather than is it necessarily true, and might that not be exactly the right number, etc. We had a bit of that experience, didn't we, with the very helpful work that we did in conjunction with Carl Farrer around variation across various things. And it's, if we can do that, encouraging our teams to really look at it from that perspective, we'll be able to then get to the really good conversations that drive change. So thank you for raising that. Susan.
Thanks very much. I think this is a real opportunity. I'm very, very passionate. I'm sure my local colleagues will be as well, about how we work on a local level and how we work collaboratively on a local level. Now, which is much smaller than a place level, to be really, really effective. So the main points that I'd raise is that we've got to really set those meaningful objectives around this in terms of what we'll actually deliver in neighbourhoods. But there's some points I wanted to make is that when we think in terms of multidisciplinary, I think it's important to think about it in its widest sense. There's a real opportunity there with local authorities and in that prevention sphere, and I know we've talked about that. This also links with the earlier conversation that we had about assets, public estates that public sector organisations have in a neighbourhood, and then those that going to be built. So all of that, really, I think, can be part of how we help create sort of neighbours and deal with issues on a local level. So, local authorities have strong relationships with neighbours, with CVS on a neighbourhood level. So it's about how the ICB links in with those existing networks. And I think, going back to your point about data, that it's how we understand the data sets and the health inequalities on a neighbourhood level, and really actually have targets around those improvements on a neighbourhood, so that we can really target effective actions collaboratively. And then the engagement with the public, again, the local authorities do a lot of engagement. So that let's avoid stepping on each other's toes. Let's do this collaboratively. I think this is a great opportunity to work really collaboratively, deliver the results that impact on things.
I really want to bank from that the engagement element and what already exists in the system, and what we already know and how we do that. We know that all partners engage extensively in various ways. What can we do as a gathering that in a really helpful way? And I think local authorities are a key driver of that. And as are the fact that our staff populations are neighbourhood populations. And I know some of us have lost in terms of how our staff live and what that works as well. So I'm going to go to George, Rachel, then Steve, and
Yeah, George Gabriel, Department for Cabinet Services. So I think we've been waiting for this quite a long time, and just I think in general very supportive of the ICB approach. I think the local neighbourhoods, the people that work in them, the people that live in them, they're the ones that know what the priorities are. And we need to give space for those neighbourhoods to shape. I think what the ICB needs to do, whether we call it light touch, how people, I think it's the right approach. I mean, there are a few things specifically that only the ICB can do and should do. One is there are resources that just have, I see data is the key one actually. The neighbourhood, at neighbourhood level, there is not the resource expertise or ability to get that good quality data. So that data is really important, highlighting the variation, population variation, variation, and feeding that into the local conversation. So I think I think there is a role for assurance, and certainly we've been asked briefly in sort of the play space to put updates on the 6 areas. I think that's appropriate and reasonable, and just working with partners to refine that. And I think that's a really, using that assurance framework to share good practice and support some neighbourhoods that will clearly need support. I think that's the third. But I think the right approach is to, let the flowers bloom and then watch attentively and then go in and provide extra attention where it's needed.
Welcome to Rachel.
Thanks, and I'm really supportive and lots of opportunity there. Recruiting young people, so they're provided published back in February. We were starting about how we get young people into these integrated neighbourhood teams, and there are people who are really keen to get involved from our providers in designing what that is for. And I think, building on Susan's point, I think there is also the work that we need to do in response to the schools and wellbeing bill around how we integrate safeguarding capability within those integrated neighbourhood teams as well, and not duplicate effort in creating additional safeguarding resources. So making sure that that board has got the right membership of the people that can be advocates for those communities across all ages is going to be really, really important. And also some of the said this morning about the evidence around complex the complications of excess weight in our children and the growth in obesity. I mean, we're putting on specialist clinics. If we can get in early and address some of those issues of deprivation for driving real morbid obesity in our children, the sooner we can.
And then just those last few comments, one of the things that we need to be able to demonstrate early, I suppose, is the is the tension that comes from needing to get around and agree data and outcomes, and then the flexibility of how individual neighbourhoods might need to get to those outcomes. And I think sometimes we don't separate those things. So we want we want flexibility all the time, or parts all the time, and but we need both. It's the right environment for that. So thank you. And then Sim, Steve.
So fully supporting them. This is a way and means to be tackling health inequality in that localised, really focused way, but perhaps it's still missing. So to give them to help us get the impact that we need. So 2 points. I think Priya's point is really well made. That's George's. It's community led, but the ICB needs to support and oversee to help, but not to interfere in the how. In particular, that's really difficult because that's something that's quite new to say to the NHS it's been community led. But so I think we have to recognise tension and recognise the learning that's going to happen. And my second point was just looking at the Darcy report. It's the first one that he wrote. He actually stated in it that it says investing in community health services must include anti-racism training to ensure equitable access. Because I think if the multidisciplinary teams are all sort of embedded in the communities but aren't sort of, they don't reflect or they don't understand their communities, again, that will stop the impact that we need. So I think we need to really dig into that. And hopefully you'll come back to us with how we can embed that within all of the work that's going to happen. Maybe ask the local authorities to help, because Bill, you will sort of have a hand in that as well. We must do people.
Okay, so hopefully this is additive and supportive of what we've got here. And I was just, there's a bit of a flavour of just some of the conversation we've had within Berkshire West Place really recently around developing neighbourhood teams. So the two kind of just provocations would be, when you're sitting around with this board, who are the 3 people you're looking at that's driving actually the development of neighbourhood teams? Who is it? Because I've heard a lot about it's collaborative, great, but who's doing the heavy lifting? Who's putting work in? What organisation is taking the lead? Is it the primary care leadership locally? Is it community trust leadership? Is it local authority? Because you're going to have to look to somebody to be in that place. And that's been a flavour of our debate at kind of Berkshire West in terms of how do we move this on in a really constructive way, and how does each organisation who are participating understand their role to play in supporting the delivery of this through some coordinated effort. And then I suppose the second point within the board, where you've got the sort of A to G, I think, listed out of the functions, it feels like what's been listed out there is also some pretty heavy lifting for the ICB. And is that what you mean? Because there's some quite chunky things in there, of not just around convening, but about data, about OD, about a number of things in there. So it's just an observation about, is that what you mean in relation to the ICB's element of drawing this together? Because that means deployment of people and time in the context of what we collectively shape ICBs over the next period. So just some practical considerations there, but certainly we're grappling with Berkshire West as well.
I think that's a real practice issue for us, isn't it? Because one of the things that we do have to be clear about is that we collectively across the system, and with the joint threats, cannot resource this unless we do it as a team across the system. But that team that can deliver it is unlikely to be owned from a national point of view by just one organisation. And we've spoken previously, and Matthew was talking about the iteration of our performance data, about having shared metrics. And we do need to see that kind of approach to this, don't we? That we, wherever we decide collectively that the ring needs to be held, and I think the decision of where it's held is a decision. It also needs to be the place that we agree the shared metrics that we are all contributing to in our individual organisational plans as they currently exist. And I think conversations that have been had in the provider collaborative and various areas across the system are about how we are all evolving to deliver for the future what is going to be needed, because actually our H1 of how we are organised now it will not deliver for the future. So I think that's such an important point for us to say when the whole point of the plan is how will it, by what method will we deliver and how will it be measured, so that we can demonstrate and continue to build that trust that this is the right thing to do and that we are the right people to be contributing to do it. So thank you. I think the degree of commonality with that, and the more that we have the counterfactual, the more that we have the challenge, the more that we have the provocation, the better we will be with the way that we take this forward in the answer.
Yeah, so just building on it, it's pretty clear that neighbourhood health and developing a comprehensive approach to neighbourhood health will be an absolute priority for the government and for our regional colleagues. So I really welcome the fact having this conversation today, and thank you for this meeting today. Yeah, Georgie, to point, it's fair to say we've danced around this particular handbag for quite some time without making huge amounts of progress. So challenge is how we're going to add a bit of rocket fuel to this programme work. So very keen to have a look in terms of reference as soon as possible. Very keen to wrap some suitable governance around the programme so we know where it's reporting to. And very keen we've got some key metrics to monitor the implementation of the programme. And then obviously need to make sure we've got the right partners in the room, etc. I think there's a real challenge in relation to harnessing best practice, but also moving quickly to a core standardised model, picking up grants approach. And we need to strike the right balance, which is not easy, because a lot of people are investing on time in their involvement and they've got relational capital to it, etc. I think if we are going to move at pace, we do need to that's aspirationally more standardised way we have done historically. And then finally, just a reflection, it's me being independent. I'm pretty sure most people, if they're asked to describe a neighbourhood, wouldn't leap to say it's a geography with a population of 100,000. That sounds to me something a bit bigger than a neighbourhood, but we are where we are.
So thank you. I think that's been a really helpful and rich conversation. We are asked to both note the work that's been done to date to support the direction of travel and the establishment of this a system programme board, and we have our sort of the basic asks of that. I think I'm hearing that we go at this with some vigour and rigour, and particularly in the fullness of time, other entities or others want to undertake any of those aspects that the programme board will currently hold as being part of our new functions as an ICB. If others want to then we can build in that. But let's assume that the entirety of this is something that we want to resource now.
I would be quick. So the strategic approach is going to be really important with this. So and how in terms of reference this is going to be really important, because what I don't want to happen is to go down a path that is actually not necessarily the right path, because I think there will be different approaches, because we need to take advantage of opportunities as well as when it's a real co-production with communities, which takes a bit longer. So I think there needs to be a lot of flexibility in there. So that definition to start with is going to be really important, with partners. I think so. I think that's my so it's a great opportunity. You know, I would say, local authorities would be really.
And do you feel so I think that is the point of the programme board, isn't it? To get us around being able to articulate that.
Okay.
And to be able to say,
yeah,
because I think unless we get, as you say, unless we start with the right interest, feeling as if they are there from day one, we can't, for example, bring the voluntary sector in at some point in the future when we say, well, this is how we think neighbourhoods health or care should, you know, we need to be broad to define in the first instance, don't we?
Yeah, so I suppose part of the question to that is who's on the programme board in terms of working on this.
So and that's the
Yes, we didn't actually say that in here because we didn't notes. Part of this discussion will absolutely inform that. Yeah, that's really helpful.
Thank you.
So I think that's right. I think that's what we need now to be the next step. Sorry.
And with that in mind, I just wonder whether it might be helpful to bring the draft terms of reference to this board in June. Because it is something that impacts on all partner organisations. And, you know, I think Susan's points are really valuable. We need to get the terms of reference right.
It may be wise to leave it to June until the meeting.
Yeah, exactly.
Yes. No, I think that's right.
August.
July.
And Nick and I obviously with our BCSE Alliance partners tomorrow, so we'll make sure that we this week, so we'll make sure that is we have people aware as well. Good. Thank you very much. Thank you. Great. Let's move then now to our Board Assurance Committee updates, and we have Sakib is going to take us, thank you, through audit and risk and system productivity on behalf of Tim Howland. We have the escalation reports, so we'll take those as read. Thank you very much, Sakib.
Okay, so just highlighting some key points. So on audit and risk, internal audit have given their opinion, or their draft opinion, which was significant assurance with minor improvements. External audit is in progress. There's a new terms of reference which are in the pack for approval. We had a freedom to speak up update, and the draft accounts were presented and will be signed off in June. Also had an anti-crime update. And on BAF, we decided that we wanted to keep the ICB and the ICS workforce risk on the basis of obviously the emerging ICB changes and the work that we're doing with Frimley. And then turning to SPC, system productivity, obviously the world has kind of moved on since the month 11 update, and we heard from Alistair the 16 million deficit, which was a lot better than where we had thought we would be earlier on in the year. Key areas of focus for this new financial year are capital, cost control, and I guess the two acutes that we were looking at last year, which both OUH and RBFT. And I did mention, even though it's not in the report, obviously I mentioned in their CIPs for in their SIPs for the financial year 25-26, one has 70% as high risk and the other has 80% as high risk. So I think that's something to look on and watch as the year progresses. We had an update from digital, and something that I know Tim always talks about is I think we need to make sure that we keep money for transformation, and we need to invest to develop and grow. And I guess that's often an area that we don't have money outside of digital to invest in. So those are the updates on those two committees.
Thank you very much. Any comments or questions in relation to this? And thank you for those who sit on those committees.
Yeah, so Keith, do we need to approve the terms of reference, audit and risk?
Yes, I believe so.
Thank you. Can I ask then probably, do we approve those terms of reference for auditions? And then could I turn to Sim, please, for people and information?
Yeah, all of them. So in a way, you've got the papers here, but this is sort of out of date, isn't it? But just to tell the board that we did go through the staff survey for the ICB, which unfortunately was, the results weren't strong. And but what was good, and you can see in the advice section that we have a really strong OD plan to take our people through. And we just cutting to the point where there was stabilisation, and that OD plan would have made a real difference. So obviously now this will change, be updated because of how we're moving forward in the NHS. But it is a shame that we weren't able to take that work through. But please note that we have good OD support and it's there, and we will use it accordingly. We signed off a couple of policies, as you can see, and there's nothing contentious on people, but please rest assured that we continue to seek assurance on how our people are feeling going through lots of things. Just in the place and system development committee, which was the last of its type, obviously this took place in April. It's out of date now, but we noted the changes that were coming. And a couple of things just to pick up on. Very pleased to hear, Priya, that you're going to speak to the BCSE, because this is what we actually looked at in the assurance part of the meeting, that we felt that really strong link that we'd built actually since the inception of the ICB should be continued and not lost. We're going to need the voluntary sector more than ever. We just spoke about it, so we noted that and we were assured that would continue. The biggest issue that we had in terms of place is just that watching the risks around the movement going forward and maintaining quality, maintaining focus on the right things. So again, that's foundation. And just taking the population health and patient experience committee, you can see the alerts, cardiac services. And what was interesting, we had a conversation about weight management, and I don't know if you've seen in the press, but there's a lot of press about people taking tablets in order to lose weight and the social feelings about that. But obviously, from the NHS's point of view, there is a challenge with regards to prescribing and costs and weights. So we've noted that, and that's something that we want to deal with going forward. The maternity, the new report, I think we were waiting for dossier for next one to be as Oxford hospitals. That hasn't come out yet, so we just wait for that to come out. And again, the risks around transitioning to again carrying on. Thank you very much. And any comments or questions in relation to those three meetings? And thank you again to everybody who participates in the launch of those meetings. Ross, did you Thank you. Good. I will now just run around the table. Any other business?
Could I just raise one point forward that I should have mentioned when we did our plan? We are now a £4 billion organisation, not a £3.6 billion organisation. If I'm referring to ourselves, we should be.
Thank you. I think that's very sobering thought about how we make sure we do spend that well.
It demonstrates the extra money that has gone into the system.
Thank you. That is a good note to end on, and it was a very good note to start on with Rebecca and Alan and Lena. Eileen and everybody doing at him for the work that they are doing and supporting. And thank you to the couple for the fact that they were prepared to make the recording. So that was very good. Thank you, everybody. Our next meeting is on the 10th of June, and look forward to seeing you then. Thank you.